We have a special offer for Follow the Money listeners on Richard Dennis's new book, Big, The Role of the State in the Modern Economy. Despite decades of rhetoric to the contrary, Richard points out that taxes and government spending don't ruin the economy, they just reshape it. For 20% off Big, The Role of the State in the Modern Economy, just head to publishing.monash.edu, select Big and enter the discount code OzInstitute20. That discount code again is AUSInstitute20 when you check out Big at publishing.monash.edu. Buy your copy of Big today.
It's much worse during the COVID period. People have gone looking for care and found it isn't there. They've been given a helpline or a number to ring, but actually it rings out. There's nothing at the end of it. People go, hang on a second, is that okay? What would I want? Do I want a new car park or a service that works?
One for mum, one for dad, and one for the country.
And there has never been a more exciting time to be an Australian.
Budgets are about choices, Fran, and you show what you value through the choices you make.
Dead, buried, cremated.
This is coal. Don't be afraid. Don't be scared.
The Treasurer knows.
Australia's basically done for. We'll just end up being a third-rate economy. You know, a banana republic.
How good is Australia?
Just follow the money.
G'day, and welcome to Follow the Money, the Australia Institute's podcast that explains big economic issues in plain English. I'm Ebony Bennett, Deputy Director at the Australia Institute, and today we're bringing you the second episode of a special series we're doing with our Chief Economist, Richard Dennis, and some special guests, based on Richard's new book, Big, The Role of the State in the Modern Economy. In Big, Richard Dennis argues that it's no coincidence that the democratic contest of big ideas has been replaced by debates about deregulation, costings, and modelling, and confected culture wars. In his book, and with this special series of Follow the Money episodes, Richard wants to start a national conversation about the shape of government, not just the size of government. So today, we're going to have a conversation about how the shape of our society and economy could change if we prioritise mental health reforms as well as funding.
Shocking new mental health figures have revealed the other pandemic gripping the country.
Today, a new report has found nearly a third of children and young people are experiencing adverse effects.
We are seeing and we are concerned about is very elevated rates when it comes to mental health impacts for our young people.
The government's announced a couple of packages, one for New South Wales, one for Victoria, helping organisations like Lifeline, like Beyond Blue.
This is $2.3 billion towards mental health services.
And it's okay not to be okay.
I'm delighted to introduce our special guest, Professor Ian Hickie, co-director of the Brain and Mind Centre at the University of Sydney. Professor Hickie was an inaugural commissioner on the Australian National Mental Health Commission and is a well-known mental health advocate. Thank you so much for joining us, Professor Ian Hickie and Richard Dennis.
Thanks, Eb. Thanks, Ebony, for the opportunity.
If I could start with you, Professor Hickie. If we had an ideal society where we did properly fund mental health and we had in place all the reforms that we need, if we had a better mental health system, what would Australian society look like?
We would really value the mental wealth of this nation. That is all the things that add up into a really productive, socially connected and inclusive society. And guess what? That would be good economics along with good social and health policy. So actually that's achievable. Talk about modelling. I'm tied up with modelling. You can model that stuff not just for its wealth, like why it's a good investment, but also for its outputs for humans. So the interesting thing, Ebony, is this is a tractable problem. This is not intractable. The question is, do we want to get organised in a way that solves the problem or persist with the ways that we have at the moment, which leave it unsolved?
So thinking of those unsolved problems, paint us a picture of some of the gaps in the mental health system that are causing these problems at the moment. What needs to be reformed?
So there are a whole lot of investments that you need to make in childhood, in development, in social structures, in parentings, in the communities, and they fundamentally play out very much in childcare in early life, in education in early life, and then increasingly in healthcare through the adolescent and youth years. You then need to have a supply chain that works in terms of effective health services, but those health services themselves have to be linked with other social services, education, employment support, housing, welfare support. And they have to be smart. They have to be linked technically so that people get the kinds of supports that they require in different combinations for who they are in the communities in which they live. So there's no average here. You can't do things on average. You have to do them in quite specific ways that lead people to lead more productive lives. And let's face it, we hate that. That's called organised, or that's called managed, or that's called coordinated. We can't stand that. We love disorganised, chaotic, unmanaged systems that we've historically and culturally inherited. So, in my view, we are reform afraid. We much prefer the certainties of a dysfunctional system versus the opportunity or the innovations that would move towards organised systems, which would be worth then putting more money into because of their return on investment.
Richard, I'll come to you next. Why, in the lead up to a federal election, aren't we having a conversation about how to spend mental health funding better, particularly after a pandemic where it's become such a central issue?
I think because we've spent decades lowering everybody's expectations. We've spent decades telling everybody that we have to cut spending, decades saying that everything government does is inefficient and all we really need to do is privatise things and outsource things. So rather than having a nice big democratic conversation about whether we think we're investing enough in mental health, whether we think the quality of the services is good enough, as Ian said, whether it's designed well enough so that it's... I mean, imagine if it was easy for people to get mental health when they needed it. Imagine if it was easy for people, just as we call 000 when we need an ambulance, imagine if it was easy for people to get acute mental care, healthcare when they needed it. So, yeah, unfortunately, because we've been trained to have low expectations, we've been trained to believe we're poor, it's just considered utopian to ask simple questions like, what if we reformed the system, made it more user-friendly, and invested more in the parts that were letting us down? Like this is literally what democracy's for, to identify the challenges we want to address and the way we want to address them. But while everyone will say we're having a crisis in mental health, and as Ian said, even though it is a tractable problem, we don't seem to think it's actually possible for us to solve it. But really it's a lack of willingness, not a lack of ability.
Professor Hickie, in the past you have been critical of the dominance of what you call activity-based funding and data for mental health care. Can you just talk to us about why you think that's problematic?
Yeah, everyone who's in healthcare, and I'm a healthcare provider myself, psychiatrist, gets paid for what they do. And if you do more, you get paid more. And the problem in mental health is we've tended to say we're not doing enough. So people go, good, let's do more. And you go, do more for what? Like, what is the actual desirable outcome here? What are we trying to actually do? Treat an illness, get someone back to work, get someone back to school, prevent suicide. What is it we're trying to do? And what is the combination of things that need to be done at various ways along those journeys to achieve that outcome? So health is entirely dominated by so-called activity-based funding, and then a reasonable price, trying to make it economically efficient for each activity, quite independent of whether it achieves an outcome or not. And we train all of our various professionals to do more of it. So we do more of it. And we have various prices. Can we do it cheaper or more expensive? Who can, and all this kind of stuff which has got nothing to do. Actually, what we do is, at the end of the day, the most expensive things: build hospitals, run emergency departments, pay for high-end, very intensive services, often for a small number of people, that actually have very limited outcomes. Some of them are socially necessary and they're important things to do, but actually overall, for the health of the nation, they don't do much, but they cost a lot of money. So every time we have a crisis, the first thing we do is spend more money on those things which actually have very little impact on the outcome because they look right. Health must require a large hospital. An emergency department seems like the obvious thing to have, not necessarily all the things before or after, or the combination of things that will prevent someone coming back to an emergency department in the future, or the sort of support for young people or for children that'll prevent them ever going anywhere near an emergency department. So we never get beyond the reactivity on the crisis and the crisis investment based on more activity at just one point in the area. And this in every area of health. People know it's dumb, but guess what? We keep doing the dumb things because politically short term, they're very good press releases. They're very good openings. They're very good pieces to show the public that you care.
Well, thanks everyone for coming for this very important announcement today in relation to a significant investment in mental health here in New South Wales.
But today, mental health and suicide prevention is one of my government's highest priorities.
Mr Assistant Speaker, this pandemic is having a disproportionate effect on those who have low incomes, making the inequality gap even bigger.
The mental health impact of this crisis has a long way to go, and for many people, 10 consultations simply won't be enough.
So if I can just clarify that I'm getting the right end of the stick here, in a crisis, we might fund, for example, many more of what's existing, maybe counselling sessions or something, but we're not necessarily focused on the outcome, just that there's more funding there for more of that particular thing. What do we know about the outcomes of mental health in this current system?
The outcomes are bad or not going anywhere. And then they were bad before COVID. And then COVID has actually exacerbated the problem because the demand's gone up. And in fact, we haven't got a supply chain that can actually respond. So a lot of people who need more care are getting less. And a lot of people who need less care are getting more. So inequity's gone up. So some of the people in greatest difficulty actually are worse off in the areas. Now, some people are better off because they've got more access geographically, economically, socially. But the end result nationally is worse. So inequity's grown during that particular period under this preoccupation with activity where the purchasers, if you're a purchaser with power because you're connected, you're educated, you're informed, you can buy more, you'll get more. So we've created actually more of a classic, entitled system when actually from the overall social situation, many of those in greatest need. Just a report out yesterday by the Grattan Institute showed that in mental health was the highest area where people were not going to care because of the cost of care. So about 18% of people surveyed did not get the mental health care they needed because they couldn't afford it. They couldn't even buy their way into our so-called universal healthcare systems. So we delude ourselves. We've got a universal healthcare system, but 18% of people with mental health problems can't even afford to enter that system. So these are big unaddressed issues in what we all pat ourselves on the back. To me, it's a bit like the discussion about, kangaroos, meat pies and Holden cars. They're all Australian. They're all fabulous. Actually, not really. They've all got limits. And so there's been an unwillingness to look hard at Medicare, at the way the state system is addressed. Are they fit for purpose in the 21st century? And are they fit for purpose for something a bit more complicated like mental health care?
Richard, as an economist, how does that description of how our mental health care system is currently working strike you? Terribly efficient?
Look, unfortunately, terribly consistent with the way we address so many other problems. I mean, look at climate change. We've got experts saying it's going to be a lot cheaper to prevent it rather than address it. We've ignored those things. Unfortunately, what we've got here is a very common pattern in Australia that because we're unwilling to have an honest conversation about the size and role of government, we're kind of always in this crisis mentality. And in a crisis mentality, we have a Royal Commission. It says, oh, my God, the system's in crisis, or we have media reports of terrible data. Oh, my God, there's a crisis. As Ian said, the easy thing for a minister to do is issue a press release. But really what we have to do is say, well, what is the actual best way to solve this problem? What's best for people seeking mental health care? What's best for the people living with and supporting people seeking mental health care? And then of all the ways that we could provide what's best for them, what's the cheapest? What's the best way to organise it? These are not complicated economic questions, but they're very difficult political questions these days, because if I said we needed to spend an extra couple of billion on mental health, the pharmacists would think we were going to take it off them, or the GPs would think they're going to take it off them, or the public hospitals will think we're going to take it off them. So we sort of set up this policy death match where rather than just say, look, we're a big country, we're one of the richest countries in the world, we always should be trying to reform our systems. And when it becomes obvious that they need to change, and it becomes obvious that putting a bit of money in now will save us a lot of money in the future, these are the things we should debate. But the crisis mentality of we're broke, we're going to hell in a handbasket, and the number one priority is we have to cut taxes, makes it very hard to say, well, we're not broke, and we could actually fix these things if we wanted to, but let's have that honest, hard conversation. So it's very expensive to keep focusing on the crisis end. Every Conservative knows we should do more preparation in the lead up to bushfire season. Every Conservative knows we should chop down all the trees so they can't burn because prevention's better than cure, except when it comes to something like mental health, in which case we just throw some money at the acute end of the spectrum.
Mental health issues are costing Australia $500 million a day.
A year we're seeing around $18 billion being spent on healthcare support. And
finding that mental illness will affect 50% of us over our lifetimes. It's responsible for 1 in 8 visits to the doctor.
Health awareness Australians are still reluctant to ask their boss for a mental health day.
Hospital emergency visits for mental illness over the last 15 years have jumped 70%. And 1 million Australians are currently suffering a mental illness, Joe, but not getting treatment.
The Commission's draft report finds that 4 million Australians are dealing with mental health issues and 1 in 7 children is affected.
Speaking of the acute end of the spectrum, just a personal anecdote. Many years ago, I had a friend come to me in crisis after he had made an attempt on his own life. And at the time, I was in contact with his family and they advised me to call the police, which just struck me as the last thing that he needed. But at the time, that was kind of all there was. If we're getting away from that acute end, what do the best types of solutions and responses look like for people who are at the acute end of things?
Well, let's be clear. You still need emergency services. Blokes at my age still have heart attacks. Some of them die. You still need acute services for acute crises. As much as possible, if people could have got better assessment before that, then you won't ever have to ring the police or an acute care service or attend an emergency department. So as much as possible, on the way up to a crisis, you want to be able to divert people, but to real care,
And, what does that look like specifically?
So, for example, I'm associated with technology products these days and other systems where if you could get online, you could actually, as Richard was alluding to, ring AAA, or better still, get on a website that said, for the nature of the problem, you put in information, you can see someone tomorrow or this afternoon or online. You can talk to a specialist now about the problem. And your family can do that, and you can do that. And that's what technology does. You think about all the things we do on smartphones and websites all over the world at the moment. Interesting about mental health is becoming international, global. Many of the providers actually will not be in Australia in the future. And if you can pay and you can connect, you'll be doing it through technology. Because guess what? They're there now. And if you're a concerned relative, friend, others, you'll get help now. Now, at the moment, that'll depend on your capacity to pay into those systems, or that someone purchases it for you. Now, in some other health systems, that's what's happening. Governments are purchasing those services from elsewhere. In fact, at the moment, the Western Australian government does that, hiring services from New South Wales, for example, to provide it to areas of Western Australia which have never had a service before and won't, but they do now with technology. So there are ways of solving these problems, backups, and then presentations. What's happening at the moment is about 40% of presentations to emergency departments are representations. They're people who've already been there and then were sent away or sent back to a service that didn't exist. So guess what? If they're still alive, they end up back there again. And so the pressure on those services is a failure to actually deal with seeing through the opportunity. So acute care is just part of a spectrum of care that's readily accessible, that's smart, that's personalised, that tracks the outcome, that knows what happens to people and actually interacts, uses new technologies to move care to where it's needed. Not the current system where you have to line up for care. You have to try and find someone that will actually deal with you, that's affordable and that is accessible. Now, this is where systems really matter. In a crisis, it's very hard to do that for yourself. This is the to use the flood analogy or the fire analogy, find your own hose, find your own boat. That's what we got, because we haven't got the services. So find your own and try and make your way to somewhere that can then help, because it's a very bricks and mortar, and those bricks and mortars and those skilled providers are in our cities, and they're in the wealthier suburbs within our cities, and then they have very high cost barriers to even get into those things at the moment. So I'm a big advocate now that technology, because mental health can use technologies in a way that a lot of physical health can't. We can do a lot of stuff in direct connections with people using technologies to facilitate both the coordination but also the provision of services. So if we were smart and we were committed to that, we would have a whole stream of services, including acute care services, that worked in partnership to get you to the right level of care. So I'm part of a sloganeering right care, first time, where you live. Interestingly, in my world, the people most interested in that are in the World Economic Forum. They're economists and social entrepreneurs. The people least interested are in healthcare. They're all lined up in their own professional societies.
Yeah, well, before I go back to Richard on the economics of it, I did just want to try and paint a picture, maybe for people who haven't experienced these kinds of things with their own family. But if you're trying to access mental health care in Australia compared to, say, if you get diagnosed with breast cancer, how is it different, the way that we approach it?
Well, it's a great analogy, because breast cancer, everybody cares. Every public hospital in Australia has an outpatient public health kind of system. We have a whole lot of systems for breast screening, for picking up if you've got a breast lump or you get a diagnosis. What happens next is very clear, and a strong sense of you must get to the specialist care centre quickly, and there is strong standardisation of what happens next, acceptable levels of service and of practice. And in fact, under the Rudd government, when that was not happening, it was much better in cities than countries, we built a whole new network of regional cancer centres, several $1 billion worth of infrastructure, because your distance from the GPO determined your survival rate from all of those things. So we built those networks and said, OK, certain levels of care are required. In mental health, no such thing exists. There is no agreement about what public hospitals will do, so public hospitals do not provide the full range of services. There's a whole set of things. Only acute care will be provided at your local public hospital. Only certain kinds of care will happen through community health care centres. Then you're told, go to your GP. Now, your GP then has to arrange to see a psychologist or to try and see a psychiatrist. Then you'll find out about the out-of-pocket costs. Fortunately, since 2001, and then more extensively since 2006, at least our Medicare services now have some reimbursement for psychology. They didn't prior to that. So that was an advance. But the out-of-pocket costs are in the order of $100 per session per person. So, how much can you afford? And if you can't afford the first $100, you can't come. Now, that's on average. Some areas like child psychiatry and other areas, it's several $100s to see anybody, and there's no matching public hospital system. So this is like being told with breast cancer, okay, well, we don't do that here, actually. And if you can afford $100 or you can afford several $100s, you can get into a breast clinic, which does start that journey. So also important to say, many people with mental health problems have become poor as a consequence of mental health. They've dropped out of employment. They've disconnected with family. So socioeconomically, they're worse off, actually. So their capacity then to buy into that circle of care is also reduced. So we've had a failure at the public health level, and then at the gaps in the so-called universality of Medicare. There's nothing universal about it at all. There are various levels of care. We often say mental health's like dental health. Why is it your minds and your mouth, two things that hurt really a lot, are not really fundamental to the healthcare agreements in Australia? And yet they're such central parts of healthcare.
Richard, I want to come back to you. Professor Hickie there has painted a real picture of, I guess, the inequalities that are at the heart of how we're approaching things now. What do we know about that impact on the economy and society?
Well, look, unfortunately, we don't know that much because we don't collect good data on it. And that's no accident, because what gets measured matters. And if we've decided that mental health care is not as important as the waiting list for hip replacements or the death rates of breast cancer, we don't have access to the timely data on waiting lists for these things. And in turn, we don't have data on regular data on the longitudinal consequences of this. So, but look, so that's what we don't know. What we do know is that prevention's better than cure. What we do know, as Ian just said, is that unfortunately mental health problems can be a cause of low income. So when we're using price to ration who gets access to mental health care, we know that we are pricing out the people who probably need it the most. Now, there's only one reason, well, there's a few reasons. The main reason you charge a price for something is you want to discourage people from using it. This is Economics 101. The purpose of a price is to ration a scarce good. So, why do we put a price on something? Because we don't want everybody to use it. Well, why don't we charge people to get into an emergency ward in a hospital? Because we do want people to use it. Why do we have free bowel cancer screening? Because we do want everybody to use it. So the mere fact that, as Ian said, we're relying on these high co-payments, these high prices, that even after you've been diagnosed as needing it, you still have to put your hand in your pocket. As an economist, the only reason to ask people to do that is if we wanted to dissuade them from doing that. And until we have that conversation and say, why on earth as a society would we want to discourage people from getting mental health care when we would never want to discourage people from getting cancer care, or we'd never want to discourage people from, getting a wound stitched up? Like, what's the point of charging for this? These are the big questions that I think as a society we need to have.
And Richard, just sticking with you quickly, there's a theme throughout the book Big that we kind of constantly deride the idea that government spending or regulation can actually improve people's lives. Therefore, we don't actually think about it constructively. How much is that approach a barrier to thinking imaginatively about how much better life could be if we did things a bit different?
It's a huge barrier. Like, we've been exposed to language for decades about the burden of public debt, that governments are inefficient, that government spending is just kind of red tape that drags down the economy. Like, everything about the national debate in Australia starts from the premise that the smaller the public sector, the happier and healthier and wealthier we'd be. But, Norway does exist, and Sweden does exist, and Germany does exist, and we can actually compare ourselves to other countries. And we know that countries that spend more on things like healthcare and childcare and aged care and paid parental leave, they're not broke, right? They're not backwaters. They're happier, they're healthier, they're more productive than us. So, yeah, unfortunately, at a big picture level, our whole debate about the role of the state, this whole fake financial crisis that we're told we always live in, means that when I say something like, why would we charge a price to make it hard for people who need it to get mental health care, most people's heads instantly go to, oh, it'd be nice to help all the people, but where would the money come from? Rather than, why are we discouraging people who need mental health care from getting mental health care? Whose idea was that? What's the plan, people? So, we unfortunately, our whole national debate constrains our thinking, I suspect.
The tool used to fight a pandemic is creating another one.
We've heard a lot of people talk about a shadow pandemic in mental health. I think it's important to realise it's not in the shadows, it's real, and it is a crisis.
We are all excited to see our state reopening, but many people continue to experience stress, anxiety and mental ill health.
With so much uncertainty in our lives, it's no surprise anxiety is growing.
We can't possibly be going through COVID and how we need to be managing COVID without it having a detrimental impact on mental health.
Finally, I want to come back to you, Professor Hickie. I feel like during the pandemic, it really shone a spotlight after a decade or more of kind of activism about reducing the stigma of getting mental health care and all of those kinds of things, put a real spotlight on, I think, how difficult it can be to access that type of care. Looking ahead to the election, what are your hopes for how we might reform the system?
I'm desperate that one of the major parties says we're actually going to do something different and innovative, and that the problem is tractable. But to do that, we're going to have to take on some of the vested interests. Everyone is much happier on the healthcare provider side with very minor changes to the existing system. And a huge amount of discussion about machinery of government, about federations, etc., and about money. Reform matters more than the money. We do need to spend more in mental health. Modelling I'm associated with says we currently spend about 11 billion. We probably need to spend 14 or 15 billion, and we'd have an efficient system if we had reform plus new investment. However, we're more likely to spend 22 billion in the future and have the same dysfunctional system, because that'll just pay providers more to do more inefficient things. And so you see a huge amount of discussion. You'll see a discussion about new national agreements, bilateral agreements. And you go, hang on a second, are you going to do things any differently? Are you actually going to take on this issue? So Richard's raised a really important issue. That price issue, not only is it a disincentive, it actually excludes those in greatest need. So if you say, actually, who are the people who really have the most urgent need? They're the poorest, and they're the most disadvantaged by geography, economics, language, a whole set of things. We should have systems that preferentially bring them in and pay the cost, not only not disadvantage them, actually support them by investment to get the care they need fastest. If any disincentives operate, they should be for those who need less, not more. So actually we have the inverse of what Richard was describing actually operating. So I'm very hopeful. Now, what happens during election year? I love election years, actually, to tell the truth, because politicians go out to real communities. And every time they do, this happened in the last election, it happened to Bill Shorten in Woy Woy, it happened to Scott Morrison in Grafton, the previous election happened to Malcolm Turnbull down in Geelong. People ask about mental health and services. They ask about what's going to happen. They care about youth suicide. They care about access to care. And your point, Ebony, is a very good one. It's much worse during the COVID period. People have gone looking for care and found it isn't there. They've been given a helpline or a number to ring, but actually it rings out. There's nothing at the end of it. People are going, hang on a second, is that okay? What would I want? Do I want a new car park or a service that works? In many regional areas, people don't want a new car park next to the railway line, which doesn't work anyway. They actually want services, human services that work and that are accessible and affordable. So I think the problem is, nationally, we're going to talk about GDP only or national unemployment rates only, and then everyone wants to have a small target. Actually, I think people would like mental health, aged care, higher education. There's a whole range of things I think people would like to work, and that economically they're as much in our interest as anything called the economy.
Well, we might wrap it up there. Thank you so much, Professor Ian Hickie and Richard Dennis. This episode was recorded on Tuesday, the 8th of March 2022, and things may have changed since recording. If this podcast has raised any issues for you, you can call Lifeline on 131114. Big is published by Monash University Publishing as part of its In the National Interest series, and you can visit australiainstitute.org.au for all our latest research and content. My Twitter handle is Ebony_Bennett with a double N double T. Richard Dennis is at RDNS_TAI, and Professor Ian Hickie is at Ian_Hickie. This episode was produced by Jennifer Macy, and you can find her at Jennifer Macy with additional editing from Louise Osborne. Our theme music is by Jonathan McFeet from Pulse and Thrum, with additional music from Blue Dot Sessions. Don't forget to leave us a review if you enjoy the podcast. It helps other people to find us. Stay safe out there, stay well, and thanks for listening.